Her name was Patricia. She was 73 years old, standing at the pharmacy counter of a Walgreens in Akron, Ohio, wearing a cardigan she'd had since her daughter's high school graduation. She handed over her Medicare card the same way she had done every month for 11 years, confidently, automatically, without a second thought. The pharmacist swiped it, paused, looked at the screen, then looked back at Patricia. "Ma'am, your cost sharing is changed. Your copay for the Eliquis is $47 today." Patricia blinked. "No, it's been $11 for 2 years." "Yes, ma'am." There was a plan adjustment. She didn't argue. She paid the $47 because her cardiologist had told her, plainly and without softening it, that the Eliquis was keeping a blood clot from reaching her brain. She drove home. She sat at her kitchen table. She opened her Social Security direct deposit notice and looked at the number, $1,412, and then she did the math in her head. The Part B premium deduction, sitting at $202.90. The new copay, the grocery bill, the gas. She was $31 short of breaking even for the month. And nobody had called her. Nobody had sent a clear letter. The change had just arrived like weather. This is not a hypothetical. Variations of this scene are playing out at pharmacy counters from Pensacola to Portland, from Tucson to Tallahassee, every single day in 2026. And most of the seniors living through it have no idea that the conditions creating that sticker shock were set in motion by a quiet sequence of bureaucratic decisions made in Washington, D.C. Decisions that didn't make the front page, didn't interrupt the evening news, and weren't trending on social media. What happened to Patricia happened because of a number, specifically $202.90. That is the new standard monthly Medicare Part B premium for 2026. It went up from $185 per month in 2025, a jump of $17.90 per month, which sounds modest until you multiply it across 12 months and realize you just lost $214.80 in annual income without anyone calling it a cut. The annual Part B deductible now sits at $283. That's another number that arrives without ceremony. These figures come directly from the Centers for Medicare and Medicaid Services, CMS, the federal agency responsible for administering Medicare and Medicaid for approximately 160 million Americans. CMS is not an obscure agency. Right now in 2026, it is being run by someone most seniors know from television, Dr. Mehmet, confirmed as CMS Administrator under President Donald Trump's second administration. The man who once told afternoon TV audiences about green coffee bean extract is now the most powerful regulator of senior healthcare in the United States. That's not an insult. It's context. And context is everything. Because simultaneously, while Dr. Oz is navigating the regulatory machinery at CMS, his boss, Health and Human Services Secretary Robert F. Kennedy Jr., is executing a sweeping reorganization of federal health priorities under a mandate the administration calls Make America Healthy Again, or MA. Kennedy's focus sits heavily on chronic disease, food system reform, and what he describes as an over-medicalized American population. Above both of them is President Donald Trump, who returned to the White House in January 2025 on a platform that included promises to protect Medicare, lower drug prices, and reduce what his administration called wasteful health bureaucracy. The executive orders and administrative directives flowing from 1610 Pennsylvania Avenue are actively reshaping how Medicare functions, who gets what gets covered, and what insurance companies are permitted to do within the Medicare Advantage ecosystem. Now here's where this gets complicated. These three men, Trump, Kennedy, and Oz, operate within a legal framework they did not write. The Inflation Reduction Act, passed in 2022 under the Biden administration, locked in specific rules about prescription drug pricing and Medicare negotiation that have significant real-world consequences for senior budgets right now, today, in 2026. The current administration has a complicated relationship with the IRA. It didn't support it. It doesn't celebrate it. But it has not fully dismantled it either, because certain provisions, particularly the Part D out-of-pocket cap, have become politically radioactive to remove. Seniors know about that cap now. Advocacy groups have built campaigns around it. Any administration that yanks it faces an immediate voter backlash from one of the most reliable voting demographics in the country. So what you have is a tension, a tug-of-war between a political team that ideologically opposes government price controls and a legal architecture that mandates them, while a separate battle over insurance, company compliance, plan design, and formulary manipulation plays out below the surface, where most seniors simply cannot see it. Patricia, at that pharmacy counter in Akron, was not a victim of any single decision. She was a victim of a cumulative effect of dozens of decisions, premium adjustments, plan tier restructurings, COLA calculations that failed to keep pace, and an insurance market allowed to quietly rebalance cost burdens from corporate spreadsheets onto individual retirees. This video is going to walk you through every layer of it. We're going to tell you exactly what changed, exactly who made a change, exactly what the law says versus what is actually happening on the ground, and most importantly, exactly what you can do right now to protect yourself. Because Patricia's story doesn't have to end at that kitchen table, staring at a number that doesn't add up. Yours doesn't either. Let's start with the number that started this conversation, $202.90. The 2026 Medicare Part B standard monthly premium. Say it out loud if you need to. $202.90. Automatically deducted from your Social Security check every single month before you ever touch it. Before you buy groceries. Before you pay the electric bill. Before you fill a tank with gas. This isn't a bill you receive. It doesn't arrive in an envelope. There's no due date stamped in red. The money simply disappears from your check in a way that is designed, whether intentionally or not, to feel routine, normal, inevitable. And that is exactly the problem. Because $202.90 in 2026 versus $185 in 2025 represents a 9.7% increase in a single year. The Social Security Administration will tell you the 2026 cost of living adjustment, the COLA, was 2.5%. The math is immediate, and it is brutal. The Medicare premium increased at nearly 4 times the rate of a COLA designed to protect your purchasing power. Let that settle. You received a cost of living raise that was supposed to account for inflation. And then the federal government, through a completely separate administrative calculation, raised your Medicare premium at a rate that consumed a substantial portion of that raise before you spent a single dollar of it. Here's how that plays out in real dollars for a typical beneficiary. If your Social Security check was $1,600 per month in 2025, the 2.5% COLA added approximately $40 per month to your benefit. In isolation, that sounds meaningful. Over a year, it's $480. That's a car repair, a plane ticket to see the grandchildren, a cushion. But the Part B premium increase, $17.90 more per month, immediately consumed $214.80 of that $480 annual gain. That leaves you with roughly $265 in real, spendable COLA benefit for the entire year. $22 per month. That is what keeping up with inflation actually looked like for millions of American seniors in 2026. And that's before you account for the $283 annual deductible, which reset on January 1st and must be met before Medicare Part B begins paying its share of outpatient services. The COLA, for those who want to understand the mechanics, is calculated using the Consumer Price Index for urban wage earners and clerical workers, a formula called CPIW. Critics, including multiple senior advocacy organizations and independent economists, have argued for years that CPIW does not adequately reflect the actual spending patterns of retirees. Seniors spend proportionately more on healthcare, housing, and food, precisely the categories that tend to outpace general inflation. The Bureau of Labor Statistics developed an alternative index called CPI, specifically calibrated to elderly consumer spending, and independent analyses consistently show it produces higher COLA estimates than the current formula. The current administration has not moved to change the COLA formula, neither did the previous one. The system, in other words, is structurally tilted, not through malice necessarily, but through institutional inertia that benefits the federal budget and disadvantages the individual retiree. Now, the people running this system in 2026. CMS Administrator Dr. Mehmet Oz was confirmed after a confirmation process that drew significant attention, some of it skeptical, much of it politically charged. His background is in cardiac thoracic surgery and, far more prominently, in television, where his program reached millions of American viewers for over a decade. His supporters argue that his ability to communicate health information to a general audience makes him uniquely suited to lead an agency that must serve a diverse, often overwhelmed beneficiary population. His critics argue that his history of promoting unverified health products makes him an inappropriate steward of evidence-based federal health programs. What matters for our purposes is what he is actually doing at CMS. Under Dr. Oz's leadership, CMS has signaled a continued emphasis on value-based care models, telehealth expansion, and what the agency describes as cutting administrative friction. There has been movement on Medicare Advantage oversight, a space that received significant scrutiny in 2024 and 2025 over prior authorization denials and marketing abuses. Though advocates argue the enforcement actions remain insufficient given the scale of documented harm to beneficiaries. Part B premium calculations, it should be noted, are not set arbitrarily by CMS. They are governed by statute and tied to the projected cost of Part B spending, largely outpatient care, physician services, durable medical equipment, and certain drugs administered in clinical settings. When CMS projects that those costs will rise, the premium rises with them. The 2026 increase was driven substantially by projected spending on Part B drugs, particularly a category of high-cost medications used to treat conditions like Alzheimer's disease and certain cancers. So the premium increase, while deeply painful for beneficiaries on fixed incomes, is not simply a political decision by the current administration. It is the downstream consequence of the rising cost of medical treatment in a system where prices are determined largely by the market and the negotiating power, or lack thereof, of the federal government. Which brings us back, inevitably, to the Inflation Reduction Act. The IRA's drug pricing provisions were designed specifically to address the cost drivers that push premiums higher. When Medicare can negotiate prices directly with pharmaceutical manufacturers, something explicitly prohibited for decades under Part D, it theoretically reduces the spending that triggers premium increases. The connection between drug price reform and premium stability is direct. That reform is now operating inside an administration that opposed the IRA. And that tension between what the law mandates and what the current political leadership prefers is the story behind the story. Before we go any further, we want to hear from you. Have you noticed your Social Security check coming in smaller than expected this year? Has your copay at the pharmacy changed without warning? Drop a comment below and tell us your state. We read every one of them, and your experience helps us understand where the squeeze is hitting hardest. To understand what is happening to your Medicare right now, you need to understand something about how federal health policy actually works, not how it is described in press releases, but how it functions in practice. Congress writes laws. The executive branch enforces them, or doesn't. And in the space between the letter of the law and the reality of enforcement, billions of dollars change hands. Quietly, continuously. The Inflation Reduction Act is a law. It passed Congress. It was signed by the previous president. It is, as a technical matter, still the law of the land in 2026. Among its most significant Medicare provisions, the federal government gained the authority to directly negotiate the prices of certain prescription drugs with pharmaceutical manufacturers. It is a power the government was explicitly denied for over 2 decades under the Medicare Part D framework established in 2003. The negotiations that began under that authority have produced real results. The first 10 drugs selected for negotiation, including Eliquis, the blood thinner that Patricia at our opening pharmacy counter was paying $47 for, had negotiated prices that were scheduled to take effect in 2026. The negotiated price reductions were, in some cases, substantial. But here is where the story gets complicated. The pharmaceutical industry did not accept those negotiations without a fight. Multiple manufacturers filed legal challenges, arguing the IRA's negotiation process was unconstitutional, that mandatory negotiation with the threat of an excise tax for noncompliance amounted to coerced speech or an illegal taking. The courts have largely rejected those challenges, but litigation has continued to create uncertainty that ripples through the drug pricing ecosystem. The Trump administration, meanwhile, has an ideological aversion to government-mandated price controls. Its stated preference is market-based solutions, competition, deregulation, transparency requirements, rather than federal negotiation. In early 2026, the administration signaled it would not expand the list of drugs subject to negotiation beyond what was already scheduled under the IRA's original timeline, and there have been internal discussions, confirmed by reporting from multiple health policy outlets, about whether to pursue legislative or regulatory action that would modify or narrow the negotiation framework. That signals matters enormously to the seniors who are counting on those negotiated prices. HHS Secretary Robert F. Kennedy Jr. operates somewhat adjacently to this pharmaceutical debate. His MAHA priorities, chronic disease prevention, food system reform, reduction in what he characterizes as unnecessary pharmaceutical dependency, position him philosophically closer to prevention than to drug price negotiation. His public statements have been skeptical of what he calls the over-reliance on pharmaceutical solutions to health problems that he argues are rooted in diet, environment, and lifestyle. There's something genuinely interesting and complex about Kennedy's position. On one hand, his focus on chronic disease prevention and food quality aligns with certain progressive health advocacy goals, reducing ultra-processed food consumption, questioning the safety of certain food additives, pushing food manufacturers toward cleaner ingredient profiles. He has pressured major food companies publicly and has initiated FDA reviews of several commonly used food dyes and additives. On the other hand, his skepticism of pharmaceutical solutions and of what he frames as a captured regulatory relationship between federal agencies and the pharmaceutical industry creates tension with the immediate needs of millions of seniors who depend on daily medication to manage conditions that exist right now, today, regardless of upstream dietary factors. You can believe that food quality contributes to chronic disease that is well supported by the evidence, and simultaneously believe that a 71-year-old woman with type 2 diabetes and heart failure needs her metformin and her Ontrasto at an affordable price today, not after a decade of food system reform. Both things are true, and the policy challenge is holding both truths at the same time. Dr. Mehmet, working directly below Kennedy at CMS, is the point of the spear when it comes to the mechanics of Medicare Advantage oversight and beneficiary protection. Medicare Advantage, also called Medicare Part C, is the private insurance alternative to traditional Medicare. It now covers more than half of all Medicare beneficiaries. And it is, by any fair accounting, a system with serious structural problems that have only partially been addressed. The core issue with Medicare Advantage is a practice called prior authorization, the requirement by private insurance companies that beneficiaries get approval before receiving certain medical services, even when those services have been ordered by their physician. Investigative reporting, government audits, and Senate investigations have documented widespread instances of prior authorization being used to deny medically necessary care, delays in post-acute rehabilitation, denials of imaging, rejections of chemotherapy protocols. CMS under the current administration has maintained and in some areas strengthened prior authorization rules that were put in place or proposed under the previous administration. There has been movement on requiring insurance companies to respond to prior authorization requests more quickly, and on reducing the volume of services that can require prior authorization in the first place. But enforcement, the gap between what the rules say and what happens to individual beneficiaries, remains a significant and documented problem. Medicare Advantage plans can also change their formularies, the list of drugs they cover, and at what cost-sharing level, on an annual basis. The protection offered to seniors is largely through the annual enrollment period, which runs from October 15th to December 7th each year, during which beneficiaries can switch plans. But the reality is that plan comparison is technically complex, The consequences of a wrong choice are financially significant, and a substantial percentage of beneficiaries do not review their coverage annually. The Part D out-of-pocket cap, a direct product of the IRA, is one of the most consequential benefits seniors have gained in recent memory. Beginning in 2024 and fully implemented in 2025 and beyond, the cap limits out-of-pocket spending on Part D prescription drugs to $2,000 per year. Before this change, there was no ceiling. Beneficiaries who needed expensive specialty drugs could spend tens of thousands of dollars annually on their medications. That $2,000 cap is law. It is not an administrative preference. Removing it would require an act of Congress, and given its popularity and the political cost of opposing it, no serious legislative effort to eliminate it is currently visible. But, and this matters, insurance companies have responded to the cap by restructuring their formularies in ways that shift which drugs appear on which tier. Drugs that a senior relied on in a previous tier may now sit at a higher cost-sharing level. The $2,000 cap protects them from catastrophic exposure, but the path to that cap, the monthly costs along the way, may have become more expensive. If this kind of clear, steady analysis is what you've been looking for, without political shouting and without agenda, this is your community. Hit subscribe. We don't break news for noise. We break it for clarity. And we are here, consistently, for the people the headlines routinely ignore. We've been talking about money, premium deductions, formulary tiers, COLA calculations. Now we need to talk about what all of that does to a human body. Because the financial stress of navigating Medicare in 2026 is not an abstraction. It is a physiological event, and the research on what chronic financial stress does to aging bodies is unambiguous, extensively documented, and almost entirely absent from the mainstream conversation about healthcare costs. A 2023 study published in the journal Innovation in Aging, reviewing data from over 5,000 Medicare beneficiaries, found that financial strain related to healthcare costs was associated with significantly elevated rates of hypertension, depression, and what researchers called prescription abandonment. That last term is a clinical euphemism for what happens when a senior stands at the pharmacy counter and makes the calculation that they simply cannot afford to fill a prescription this month. Prescription abandonment is not a financial problem. It is a medical emergency in slow motion. When a diabetic patient stops taking their metformin because the copay became unmanageable after a formulary change, blood sugar control deteriorates. When that deterioration is sustained over weeks and months, the downstream consequences include nerve damage, kidney damage, and cardiovascular events. The cost of a single diabetic hospitalization, often $20,000 to $40,000 or more, dwarfs the cost of 12 months of medication. The system is creating the emergencies it then charges to treat. This is the pattern that Robert F. Kennedy Jr. is, to his credit, tried to address at the upstream level. His MAHA agenda's emphasis on food quality and chronic disease prevention acknowledges that the American healthcare system has been extraordinarily effective at treating acute conditions and extraordinarily ineffective at preventing the chronic conditions that consume the majority of Medicare spending. Approximately 86 cents of every Medicare dollar goes toward managing chronic conditions: diabetes, cardiovascular disease, chronic kidney disease, obesity-related illness. Kennedy's argument, and it is not without merit, is that you cannot prescription drug your way out of a population-level metabolic crisis. That the food environment, the chemical environment, the sedentary structure of modern American life are producing illness at a rate that no amount of pharmaceutical innovation can fully offset. Where that argument runs into immediate real-world friction is the timeline. Food system reform, assuming it is pursued aggressively and successfully, will produce measurable population health improvements over decades. The senior sitting in Clearwater, Florida, today managing stage 3 chronic kidney disease and type 2 diabetes, needed the problem solved 20 years ago. The intervention available to them now is pharmaceutical and clinical, not nutritional. And if the cost of that pharmaceutical intervention is rising faster than their income, they are caught in a gap that no amount of Mahavision can currently close. This is not a criticism of the vision. It is a call for the vision. and the immediate needs to be addressed simultaneously. Prevention and access are not competing values. They are complementary ones. The failure of American health policy across administrations of both parties has been the consistent inability to hold both at the same time. Now add to the financial stress something that is documented but rarely discussed with the candidate it deserves: the health impact of insurance complexity itself. Navigating Medicare. Traditional Medicare, Medicare Advantage, Part D, supplemental Medigap coverage, prior authorization requirements, formulary tiers, network restrictions, annual enrollment decisions requires cognitive bandwidth that the system has never formally accounted for. For a healthy 67-year-old with a graduate degree and a reliable internet connection, it is manageable, though still frustrating. For a 79-year-old with early-stage cognitive decline, limited English proficiency, no nearby family support, or significant vision impairment, it can be genuinely impossible. The consequence of that complexity is not neutral. People who cannot successfully navigate the enrollment and covered decision process end up in the wrong plans, paying more than they should, losing access to providers they've seen for years, or missing benefits they are entitled to. Studies on what researchers call choice overload in Medicare Part D, there can be dozens of plan options in a single county, have found that beneficiaries consistently make suboptimal choices when presented with too many options and insufficient decision support. They default to what they had last year, even when a significantly better or cheaper option is available. They avoid making changes because the process feels overwhelming. They end up paying hundreds or thousands of dollars more annually than necessary. That financial drain, entirely legal, entirely structural, contributes directly to the budget pressure that then causes prescription abandonment, dietary compromise, and deferred preventive care. The insurance companies operating Medicare Advantage plans understand this dynamic. Their actuarial models depend on it. A beneficiary who doesn't comparison shop is a beneficiary who stays in a plan that may no longer serve their best interest. The plan's marketing budget, visible in the avalanche of direct mail, television advertising, and unsolicited phone calls that descend on seniors every fall, is not designed to help them find the best plan. It is designed to retain existing enrollees and recruit new ones. CMS has rules governing Medicare Advantage marketing. Under Dr. Oz's leadership, there has been attention paid to misleading advertising practices, and the regulatory pressure is real, though advocates argue it remains insufficient relative to the documented scope of the problem. The physical consequences of all of this, the stress, the cost pressure, the prescription abandonment, the deferred care, show up not in policy documents, but in hospital admissions data, emergency room utilization rates, and the quiet suffering of people who are managing chronic conditions on budgets that have been squeezed from multiple directions simultaneously. The $202.90 Part B premium deduction is not just a line item. For millions of seniors, it is a monthly reminder that the system was not designed with them at the center. Everything we have covered in this video, the premium increases, the COLA math, the regulatory tensions, the formulary restructuring, the physical toll of financial stress, can feel, when laid out in full, like a wall you cannot get past. It is not. There are specific actionable steps you can take right now to reduce your exposure, protect your benefits, and make the system work significantly better for you. These are not workarounds. They are your legal rights and your legitimate options. Most seniors are never told about them in this kind of clear, direct language. Let's go through them. Step 1. Contact your state SHIP program. SHIP stands for State Health Insurance Assistance Program. Every single state in the country has one. It is a federally funded program that provides free, unbiased, one-on-one counseling to Medicare beneficiaries and their families. SHIP counselors are not insurance salespeople. They are not affiliated with any plan. They cannot receive commissions. Their only purpose is to help you understand your options and make informed decisions. SHIP counselors can review your current Medicare coverage, compare it to available alternatives, help you understand a coverage denial, assist with appeals, explain your rights under the IRA's prescription drug provisions, and walk you through the Extra Help Program, a federal subsidy program for Part D costs that a significant number of eligible seniors never apply for because they don't know it exists. You can find your state SHIP program by visiting shiphelp.org or by calling 1-800-Medicare. Write that down. Step 2. Run a Plan Finder audit before every annual enrollment period. The Medicare Plan Finder tool at medicare.gov is free, and it is genuinely powerful when used correctly. Every year, before October 15th, the start of the annual enrollment period, you should sit down with a list of every prescription medication you take, including the doses, and run them through the Plan Finder for your zip code. The tool will show you every available Part D and Medicare Advantage plan in your area, what those plans charge for each of your specific medications, and what your estimated annual cost would be under each plan. The differences can be staggering. Two plans with similar-looking premiums can differ by thousands of dollars in annual drug costs for the same beneficiary, depending on how their formularies are structured. Most seniors do not do this. The process takes an hour, maybe two. The savings can be $1,500, $2,000, or more per year. If the technology feels difficult to navigate, your SHIP counselor can run this analysis with you or for you at no cost. Step 3. Understand the Part D out-of-pocket cap and track your spending. The $2,000 annual out-of-pocket cap on Part D, spending that took full effect under the Inflation Reduction Act, is one of the most significant beneficiary protections in the history of Medicare Part D. But to benefit from it fully, you need to track your cumulative out-of-pocket spending through the year. Keep a simple log, a notebook, a spreadsheet, whatever is comfortable, recording every dollar you spend out of pocket on covered Part D prescriptions. Once your spending reaches $2,000 in a calendar year, your covered medications cost you nothing for the remainder of that year. If you're not reaching the cap, but your costs feel unmanageable, that's a signal to revisit your plan choice. If you are reaching it and spending heavily in the early months of the year, the new Medicare Prescription Payment Plan, another IRA provision, allows you to spread your out-of-pocket costs across the calendar year in monthly installments rather than paying large amounts up front. Ask your pharmacist about the Medicare Prescription Payment Plan. Ask your SHIP counselor. This provision is real and it is underutilized. Step 4. Know how to appeal a coverage denial. Whether you are in traditional Medicare or Medicare Advantage, you have the right to appeal any coverage denial. This is a legal right, not a courtesy. If a prior authorization request is denied for a medication, for a procedure, for post-acute rehabilitation, you can request a redetermination from a plan. If that is denied, you can escalate to an independent review entity. If that is denied, you have further appeal rights through the Office of Medicare Hearings and Appeals and beyond. The appeals process has real teeth. Federal audits and independent analyses have found that a significant percentage of initial coverage denials that are appealed are ultimately reversed. Plans know this. Many denials are reversed at the first level of appeal. The problem is that most beneficiaries don't know they can appeal or don't know how, or find the process intimidating. Your SHIP counselor can assist with appeals. Your state attorney general's office has a consumer protection division that fields Medicare complaint inquiries. The Medicare Rights Center, a national nonprofit, provides free counseling and assistance at medicarerights.org. Step 5. Report marketing violations. If you receive misleading marketing materials, unsolicited calls from Medicare Advantage plans outside of permitted hours, or materials that contain factually incorrect information about plan benefits, you can report them directly to CMS at 1-800-Medicare. CMS has civil monetary penalty authority over plans that violate marketing rules. Complaints from beneficiaries are one of the primary triggers for regulatory investigation. Your report matters. Step 6. Understand the Medicare savings programs. If your income and assets fall below certain thresholds, you may qualify for a Medicare savings program, state-administered programs that pay some or all of your Medicare premiums, deductibles, and cost sharing. The income limits are higher than many people assume, and the programs are chronically underutilized because eligible beneficiaries simply don't know they exist. There are 4 tiers: the Qualified Medicare Beneficiary Program, the Specified Low-Income Medicare Beneficiary Program, and 2 additional levels, each covering different components of Medicare costs. A SHIP counselor or your local Medicaid office can tell you in minutes whether you qualify. Step 7. Stay engaged with policy. The decisions being made right now by President Trump's administration, by Secretary Kennedy at HHS, by Administrator Oz at CMS. Decisions about the scope of IRA drug negotiations, about Medicare Advantage oversight enforcement, about formulary flexibility, will directly affect what your coverage looks like in 2027 and beyond. The annual enrollment period for 2027 coverage begins October 15th, 2026. The decisions being made in Washington right now are already shaping what choices will be available to you. Staying informed is not passive. It is protective. Following credible, nonpartisan health policy sources, KFF, the Medicare Rights Center, the National Council on Aging, gives you lead time to respond to changes rather than being surprised by them at the pharmacy counter. You are not powerless in this system. The system is complex, and the interests arrayed within it are large and well-funded. But the tools to navigate it, protect yourself, and advocate for better outcomes exist, and they are available to you at no cost. Patricia, in Akron, did eventually call her SHIP counselor. She switched plans during the annual enrollment period. Her Aliquis copay went from $47 back down to $9. Her annual savings were over $450. She told the counselor she wished someone had told her she had options. Someone is telling you no. If this video gave you clarity that you couldn't find anywhere else, if it helped you understand what's happening to your check, your coverage, or your costs, please share it. Send it to a spouse, a sibling, a neighbor who you know is struggling to make the numbers work. These are conversations that mainstream news isn't having clearly or consistently. That's why we're here. Like the video if it delivered real value. Share it if it could protect someone you love. And we will keep doing this. Steadily, clearly, without noise, for as long as it matters. Which is for as long as the system keeps making it complicated.